Hi, everybody. This is Brian.
Good afternoon, Brian.
Hey, Brian.
Hey, Dr. Halford. Hey, Patty.
Hey, how are you?
Good. How are you?
Doing well, thank you.
All right.
Hey, Brian. Grace Wu here.
Hi, Grace. How are you this morning? Or this afternoon?
Doing well, thanks.
All right, good.
Hey, Grace, it's great to hear your voice. Haven't talked to you in a while, so.
I know, it's been a while. How are you guys doing over there?
We are surviving one day at a time. How about for you?
About the same.
Jigger, are you on as well?
Yes, I am. I'm just grabbing some lunch, so I'm not in front of my PC yet. So sorry, you can't see
All
me.
right, no problem. That's all right. Ashley says hi. She just stopped in here before the call.
Yeah, I seem to be getting a lot of notes from your wife.
Yeah. I would tell her to knock it off if she's giving you too much work.
Oh, no, it's actually going in the other direction mostly, so it's okay.
Oh, okay. Well, she didn't say anything bad about you, so I guess it must not be too much.
Well, that's good then.
Looks like we have Paul and Sandy on.
Yes, hi.
Hi, Brian.
Hey, Paul. Paul, hey, Sandy. Thanks for joining. You guys will start to get busy here, huh? Over the next few months. 2 new hospitals.
Yep.
Sure.
Job security.
Exactly. All right, we'll give it just another minute or so here and see if we get anybody else to join, and then I think we can get started. Hey, Tiffany.
Hey, Brian, how are you doing?
Good, how are you today?
I'm great, thank you. Sorry, it took me a minute to get to my mute button.
Oh, no problem. All right, well, it's about 3 after. We may have some more people come in here as we get a little bit further along. But thanks everybody for joining here today. It's our first meeting here in 2021, so welcome. And I know people are probably still busy. There's a lot of COVID-related activities continuing to go on, so I appreciate you carving out some time here during the middle of the week to continue these discussions. I have a few items that have been sent over to me for the agenda today, but as always, this is one of our open discussion meetings. So I want this to be where we can just ask any questions that may come up and make sure that we're available to answer those and discuss them here within this group. So as we're going through this, just think of any additional questions or comments or things that you're doing in your organization that you may want to talk through. But Dr. Halford, I may kick it over to you and in relation to the COVID vaccine workflow, and then if you just wanted to talk through what you're doing, and then maybe we can open it up to any questions that you want to give to the group.
Thank you, Brian. I think on the last call,
Yep.
we all just kind of started the conversations of where we're at as far as COVID vaccine, and felt that it would be good to keep that on here as a standing agenda item, at least for the foreseeable future. I know everyone last time was really in kind of the discovery mode of what they were going to do for patients. Everyone obviously already had their processes together for employees and healthcare workers. I'm happy to share, what we've been doing at Covenant thus far. We are kind of in a transition mode as far as next steps and moving forward, but we ended up building a schedule under the ambulatory organizer in Cerner for our vaccine clinic, and utilized the call center in the beginning to schedule those appointments. Went ahead and scheduled the first and second dose up front. That did cause some challenges for us because we're basically doing a outside clinic with 2 tents, much like some other health systems and health departments, and so it wasn't just as patient friendly as far as the location of the clinic being correct and additional items. The other thing that lacked is the ability for patients to do online self-scheduling. And so we have been through a process of evaluating vendors and building an online schedule, kind of moving forward. But I think this group just had some open discussion last time about using the mass vaccine module versus using the more typical vaccination workflow and ambulatory. And it sounded like that we wanted to just kind of come back to a follow-up discussion in this group. Anyone else
Yeah, absolutely.
have some comments or questions or struggles that they're dealing with there?
Hey, this is Dr. Wu at Murray Regional. I will kind of share what we did. We attempted to build out the mass vaccine pages and tested it quite a bit, and found that we weren't able to attach the correct medical services and encounter type by checking them in through the mass vax pages. So we were going to do a similar setup as what Dr. Halford's describing in terms of having an ambulatory workflow designated for the clinic. We kind of had a little bit of a wrench thrown at us in that our local health department we decided to turn over all of our vaccine to the local health department to distribute based on criteria. So we never really completed that, but I think we were finding the same things in terms of workflow, that not necessarily the mass vax pages were going to be the most useful to us. We were in the process of possibly relaunching our own vaccine clinic here in the next week or two. And so I was interested to hear that you guys already have, I guess, a pretty robust call center to maybe handle some of these sign-ups for the patients, but we haven't really found a way either to do online self-serve sign-ups like you're describing as well.
Thanks, Dr. Wu. It is definitely ever-changing as far as collaborating with the state and the local health departments, and sometimes the plan changes on a day-to-day basis. So I understand where you're at, and if you all do expand and you want to chat, feel free to reach out.
Thank you. The one thing that I will say that I found to be very helpful, which I had never really looked at before in Cerner, was the process of uploading or downloading or extracting information from the tennis system back into the Cerner chart. And because so many of our local vaccines haven't been done within the Cerner system, they've been done at the health department, it's actually been very nice to see how easy it is to get the vaccine information from tennis into our system. So even though it's not working out as we had initially hoped in terms of using Cerner to distribute the vaccine, it is very easy to push that information back into our system.
Is that an interface you have set up, or is that just a file that you're uploading? How are you doing that?
There is something in the immunization forecaster or the immunization component where you can import data from the state immunization website. And so
Okay.
I don't think we had to build any of that in. It looked like it was readily there, since I think some of our ambulatory clinics already use that process to get vaccine information as well.
That's similar to
Brian,
our
for
setup at
you.
Covenant as well. We didn't have that in the beginning, but once the state of Tennessee opened up those capabilities, we also have bidirectional. We can go out and query the state, or if any vaccine's administered in Cerner, then we pass that along to the state.
Yeah, Brian, that's through Cerner's immunization registry tools through our interoperability set of things. That's standard in most states. Every state's a little different. They just happen to both be in Tennessee, so they have the same thing. Tennessee and Indiana, it's CHIRP, and there's different states have different things. But in Tennessee, it's pretty, it works well, it seems.
Perfect. Thank you. Sandy or Paul, did you want to walk through anything that you're doing at Concord about immunizations? Or
Hey, Brian, sorry about that. I was muted.
hey, oh, no problem.
So yeah, New Hampshire's a little different in that they don't have their own state vaccination website or portal. So originally everything was being done through VAMS. And so Concord Hospital was originally using the VAMS website to schedule and administer the vaccines. The tricky part came when the vaccines in New Hampshire opened up to the general public. Then those local or hospital-based sites were showing up as available to the general public. And then folks were scheduling appointments for clinics that were designed only to vaccinate hospital employees. So they quickly had to kind of de-escalate the hospital-based clinics for employees. And we still have a clinic site here, but we're no longer scheduling through VAMS and doing that through a different process now. I know John and others have been working with Cerner. I'm not sure though that we've fully turned over to using the Cerner vaccine module. I think they did start using that recently. We can get an update for that though and get back to you.
Sure, that would be great. Thank you for that, Sandy. Chris, I think you joined as well. Did you want to give any update on how Penn State is doing?
I did. Thanks for having me. Apologize. I'm going to have to leave a little bit early as well. We've been using the Cerner mass vaccination module for all of our employees. We're actually starting to ramp down that employee vaccination process. We've actually got a pretty decent number of people vaccinated, so it's a matter of people self-selecting out, which turns out to be about 20% of our population. So we're getting about 80% vaccinated, which is a decent number. The challenges around public vaccination remain. We are vaccinating in our local clinics, about 7 or 8 of them, with smaller volumes of vaccine, just because based on its availability, and we are using the Cerner EMR and the mass vaccination module process there. But as we move to large venues for high volume vaccine, we're going to pivot likely to Salesforce.com to help us with tiering, self-scheduling, and immunization components of it. We're working on the last piece, which is reporting to the Commonwealth of Pennsylvania to ensure that we then get it back into our electronic records through the state repository.
Thanks for that, Chris. Does anybody else have anything they wanted to talk about around COVID, or anything that they're doing to prepare as we kind of, as Chris mentioned there, pivot to public vaccinations?
Jigger, do you want to comment? Thank you for adding information to the chat. I understand both Cerner and some other clients have used the mass vaccine module effectively.
Yeah, and if anybody's struggling, I can connect you. This is a Cerner team that's helped this particular client, and they'll be more than happy to talk through some of their nuances. They were doing it for their employees, and they were averaging, I have statistics on it, but their first day they did 500 in using the Cerner tools. So it was an effective process. We have some timers and everything else, and on average between the three stations, from a registration station, a screening station, and a actual administration station, the process in the EMR for each of those was 2 to 4 minutes on average, so pretty quick. And the mass vac pages and the tools that Cerner has made from a front-end code use perspective seem to be working there. So there are nuances, obviously, especially if you're dealing with employees versus the public. I think in general, what I've heard is that the scheduling is definitely something that needs work and needs solving for more holistically, because it's hard to manage that from a call-in center perspective or anything like that. Otherwise, many of you have AMS services, and they're doing a lot of the across the client base, making sure all the right packages, orders, billed, et cetera, are all there. And then folks like myself and others are helping on the front end. So if you do need a quick consultation, we can help facilitate that for you.
Thanks.
I appreciate that, Jigger. Great. Well, the next item that I had on the agenda, it came from Sidra Health, and they had asked me this question a week or so ago. And Dr. Halid there is looking at some of the clinical governance structure that the hospitals have set up. He's kind of looking at it really from a pediatric centric focus, since that's what their hospital primarily is. But he wanted to ask, and I don't see him on this call, but I think it's still a worthwhile conversation about how organizations have set up their clinical governance, how if you have clinical informatics, how that reports up, and kind of what that overall structure looks like. So if we want to just kind of talk about how we have the clinical operations reporting, whether it's to a CIO, CMIO, how that goes, we can maybe take these notes. And I think that might be something good for us to put in our matrix of what each organization has as well. So we can reach out and talk to organizations like that also. So maybe we could do a roundtable on that as well, and kind of give a high level of maybe how the organization is set up, but primarily the clinical structure. And Dr. Halford, I don't know if you wanted to kind of get us started. I think I know how you work, but then for the overall group, we just kind of wanted to go over that.
Sure, no problem. So I'm the CMIO at Covenant Health, and I report to the EVP of Operations. Obviously, I have to work very collaboratively and close with our CIO. and also with our chief medical officer and chief nursing officer. Tiffany Cross is on the call with me today, and she is an informatics officer over our ambulatory and diagnostic services. And she has a counterpart, Chris Skinner, who is informatics officer over nursing and physician pieces for the acute world. And so we work very closely together, and I have quality and consumerism and telehealth and pharmacist on my team, and then the bulk of the analysts on the clinical side are on Tiffany and Chris's team. So that's the gist of the reporting structure. I could probably talk all day about our governance structure. We have a very strong governance structure. I'm happy to share that and talk about it more if we need to at some point.
Maybe that could be a future meeting when we do one of our innovation sessions, if you want to bring that back. And I think that would be good, because I know Chris did something sort of similar at our last meeting. So that might be good to get another perspective as well. But I think this is a good high level overview. Kind of look here. Paul or Sandy, did you want to cover it for Concord as well?
I'll take a stab at it. I'm not sure that I have a complete grasp of who reports to who, but we have an informatics department, and we have, I think, 3 provider informaticists, a couple of pharmacists that are full-time in informatics, a bunch of nurses and a bunch of analysts. And nominally, Holly Ellison is who's a nurse, is the director of the informatics department. Paul Clark is our CMIO. They sort of work side by side, Paul and Holly. Paul reports to our chief clinical officer, which is kind of a hybrid chief medical officer and something else, a little bit more involved with operations than a chief medical officer normally would be. Sandy, do you have anything to add to that?
No, I think that covers it. I think we did a lot of reshuffling in the past couple of years with bringing some of the analysts and nursing informaticists onto the same team because they were sort of in separate buckets previously, and by bringing them under the same directorship, it really kind of gives us more of a unified approach. In some areas, when we have implementations and things like that, we try to do like a 3-legged stool approach with teaming up an analyst, a nurse, and a provider informaticist on specific projects.
Yeah, I think that's a really great structure to have there, and I feel like it's working out well for you there.
Yeah, I think it's taken a few years to really get to where we are now, but I think it's been well received. I think the team functions at a really high level, and obviously, as you know, Brian, the leadership is phenomenal. So I think that has really worked out to our benefit.
Absolutely. Thank you. Grace, did you want to fill us in on your org structure?
Yes. So we're at, I'm at a smaller regional hospital. We have our main flagship hospital, which is Murray Regional, and then a couple of critical access hospitals. So not quite as big as Covenant and Concord that you guys are referencing. So our structure is somewhat different. I'm the CMIO. I report to our chief medical officer. I work closely with our CIO. We did have a director of clinical informatics, but she unfortunately was downsized during some of the COVID initial phase out last year. So the people that I mainly work with are 2 clinical informatics coordinators who are very well experienced in critical care, floor nursing, and the emergency room nursing needs. And so they kind of help shuffle and prioritize projects for their groups and work really closely with the clinical IT analysts. Our IT analysts are all housed under our CIO and IT. And so in addition to that, we also have a couple of ambulatory directors who have been very involved in our implementation of Cerner over the past 3 to 4 years. And so they handle a lot of ambulatory needs and then prioritize certain things that come in front of me to kind of help coordinate, especially if it relates to physician build requirements. So that's us in a nutshell.
Great, thank you. And then Chris, did you want to give a brief overview as well?
Yeah, I think the word matrix comes to mind. So let me see if I can figure it out. I serve as the corporate CMIO, which is a relatively new couple years move from being CMIO of the Hershey Medical Center. I have associate CMIOs either in place or hiring for the acute care hospitals. They report to me. I have directors of medical informatics. They're ambulatory physicians per region that have a dotted line to me and a direct line to the medical director of that region. We have 5 regions in our ambulatory space, given the geographic disparity of central and rural Pennsylvania. We have a growing number of informatics nurses, coaches, and educators, which for the longest time were disparate amongst various hospitals and other locations. They are starting to be recollected and realigned to under IT. They actually report up through to the chief applications officer, which is a little bit different than every place I've heard. I report to the CIO and the chief clinical officer, which is similar to what I heard before as the lead clinical person for the health system.
So you kind of have a dyad reporting system there then?
A lot of ours are dyad at best reporting systems. Sometimes they're triads and quadrads and quintads and add a bunch of ads. But you know, from a you have to have official sort of HR reporting structure. So the official HR reporting structure for me is to the CIO. But the functional report is a combination of the CIO and the CCO, so that we can get all of the chief medical officers and chief nursing officers and ambulatory medical director leads kind of herded together. But yeah, it's a very relational based matrix activity here.
And I'm seeing that more and more at a lot of organizations as well. Like you said, functionally you report to one person, but HR sort of has a dotted line to another person. So that's interesting to see you have that function.
Yeah, it's very interesting. I, over the years, had report to the clinical space for a few years, and they'll bounce it back to the IT space, and they'll bounce it back to the clinical space, and they'll bounce it back to the IT space. The roles and functions really don't change, and I'm not a fiefdom builder, so it doesn't really matter to me as long, you know, the whole thing around getting informatics nurses and coaches and educators. While I think most would have them aligned to the CMIO as a direct report. It doesn't doesn't bother me. Matter of fact, it's easier from a day-to-day work perspective. They don't report to you. That way you don't have to do all the HR stuff related to it in practicality. But as long as you have them aligned to those activities. And we're talking really a lot of applied informatics types, right? The ones that are there for go lives, that are aligned to service lines, that go do support, that thing. So there's a whole nother bucket of analytical informatics types that are doing a lot more data crunching and data governance. And so Jigger put a little note out there. So there's a whole nother group really that functions in the enterprise information management space for us that looks at the analytical informatics. I consider them part of my matrix team. But again, they report up through the director of data warehousing.
Yeah, that's an interesting one. And Jigger, I saw that you put that in our note as well, that you're seeing that happen more and more. Is there anything you wanted to talk about with that?
No, I think just, from an overall arching kind of for Dr. Khalid and the notes, from an overarching kind of view at Cerner clients in general and informatics in general, I think what's been shown here and talked about here is it's a wide representation. CIO is one, CMO is one. I've even seen a CFO or a COO type relationship from a CMIO perspective. And then to Chris's point, the matrix is in full effect across that. I am seeing in a couple places more of this breakdown of IT from not just a CIO, but also a director of applications, and then technology, and then more infrastructure type network and CISO type work. So it gets very difficult and often very convoluted when you have to figure out who a decision maker is. And my advice to Dr. Khalid and others is just make sure you understand the reporting structure is important, but who are the decision makers, right? And what's the process by which that group can make a decision is as important as reporting structure. So if you frame governance in a decision frame, that often lets the rest of that stuff kind of melt away, and that'll be and I've seen it work quite well. I've seen people and when they focus on that, they often make decisions faster.
Yeah, it's a really good point about making sure that your decision makers are well outlined there. Because I think, as Chris was saying before I had to jump off, it's kind of a little bit of a pendulum on who you're reporting to. But as a decision maker, he's probably still that, regardless of whether you're reporting to a CIO or a CMO. So yeah, that's a good thing to always keep in mind. I think I called on everybody. Does anybody else have anything on governance structure or data analytics or anything like that they'd want to talk about? All right. Dr. Halford, I'll come back to you here. You want to talk about the follow-up workflow for inpatient? Just have a conversation about that.
Yes. Thanks, Brian.
Sure.
I had hoped to pull a presentation together, but I apologize. I really just didn't have the bandwidth to be able to do that this week. I really wanted to have some open discussion with the rest of the teams to find out what workflow they're following for scheduling follow-up appointments in the hospital setting. Not really talking about ER, but acute. I'm happy to share my screen and show our domain at least. So if you give me just 1 second. Just curious if others are using the workflow in pages follow-up component. Brian, can you all see my screen now?
I
Yes,
can
we
see
can.
it.
Okay, thank you. We've just had several challenges with the follow-up component, and we've been partnering with Cerner with Jigger's help to try to talk through what are some optimization items that we could work on. But for example, if the majority of our patients are admitted to a hospital as service, when we want to schedule the follow-up appointment, we want it to be with our primary care physician. And we have the primary care physician flowing here from the registration module. But the way the component works, when you click on this, it just automatically adds the appointment without any additional details. And so you have to think about going down here to this section and modifying and putting in, I want that to be in, within 3 to 5 days, or, whenever the follow-up appointment is, et cetera. And so a lot of people are either missing that, or they're kind of going past the primary care physician field that's pulled in automatically for them and going straight down to the follow-up with primary care provider. We, with the template build that's behind this follow-up component, we haven't found a way to auto-populate or default order sentences, for lack of a better term, on these follow-up options. If we do see one, it kind of defaults for all. I can't pick to default primary care to 5 to 7 and specialists to 2 weeks, et cetera. We want to continue to use the component workflow because of the way it flows to our patient instructions and our discharge summary, and really, and also to the HUC and to nursing for their process in discharge. However, and part of this is just kind of moving so fast with our original implementation for our surgical workflows, specifically same day surgery. We built them an orderable, and that orderable has all the correct details. And so we've kind of been in this dual workflow state, and where some patients have an order and others are filling out the follow-up component. So I was just kind of curious what other workflows you all are using, and if anybody's struggling with any challenges.
This is Sandy O'Laughlin from Concord. I was really interested when I saw you were going to be talking about this today, because we've had similar struggles. We're using both an order and the follow-up component. Actually, when I just did some testing on the phone with you, I can see that ours actually does have a default time frame. When I add our quick picks, it defaults in time frame of 1 week, and then I can modify that if needed. But I think what has been the struggle for our organization is that it's not clear to the end users what is going to print out on the discharge instructions. So we currently use a depart process for discharge instructions. We're not using a DynDoc, template or anything like that. So oftentimes folks think if they type details into a follow-up order that's going to print out on the discharge instructions, but the template is built to pull from whatever is put into this component. So I think because we have the order itself, which will feed to either a health unit coordinator or care management to try to make an appointment for the patient, that's one piece of it. And then they're supposed to turn around and come in and enter the follow-up appointment into this component in order for it to be visible on the instructions for the patient. I think that's a lot of moving parts, and that's caused a lot of confusion in our organization. And I wish we had a better way to capture that.
Thank you. I mean, we're kind of seeing the same thing for the order. We have tasking for nursing to do, and of course they love tasking. So we're actually looking at creating a custom rule that if the follow-up was done in the follow-up component, that we could also fire a task for nursing to help with that piece. We'd love to kind of, to your point, get to one workflow, either use the order or either use the component. And we feel like that there are more reasons to move towards the component.
Yeah, I think
we're still in the midst of determining.
One of the struggles we've had is that the follow-up order can be ordered outside of a power plan, so it could be single searched anytime, but it also lives in the discharge power plan, and the discharge power plan is not initiated until the patient is just about ready to go out the door. So to me, there's little value in, we type in patients should see their PCP in a week, or patient needs to follow up with cardiology in 1 to 2 weeks. And then we're initiating that as the patient's about to go out the door. So that doesn't give a lot of leeway then for someone to go in and make an appointment for the patient and then come and enter it into the component. And when the order is entered on the discharge power plan, that information doesn't even, it's not forward facing to the patient either, unless someone takes the time to then type that same information or the appointment itself into the component. So I think that it's just confusing for end users. I think we all understand what the difference is, but the end users do not. And we've had, many situations where somebody types into that follow-up appointment order, it never gets done, and then there's no follow-up that's arranged prior to the patient leaving. One of our initiatives has been, all hospitalized patients really should be leaving the hospital with an appointment for follow-up. And that's been a goal, but it's been difficult because providers and hospital staff don't have access to schedule the appointments themselves. So that's another piece that's complicated.
Hey, this is Dr. Wheeler Murray. We use the follow-up component for inpatients in particular pretty much across the board. And I think on some of our same-day surgery cases, the surgeons might still be putting a follow-up appointment order. But by and large, on inpatients, we're using the follow-up component. And we have we don't necessarily have a task that fires for a nurse or anyone else to make the appointment, but our unit clerks and the nurses both know that if they see discharge orders on the patient, that they are supposed to go look at the follow-up or at the discharge end page and review that follow-up component. And they're the ones responsible for making the appointment for the patient before they leave. For us, I think that, and you guys, I think, have echoed this sentiment already, but the main reason that we've been emphasizing the follow-up component is that, A, it pulls into our discharge summary, and it also pulls into the inpatient discharge instructions, so that what the physician is documenting is also mirrored in what the patient takes home. So I think in rare instances where follow-up appointment orders are being placed, we also have the unit clerk kind of addressing those as well. But as I said, I think the vast majority of inpatient discharges are being handled through the discharge workflow in the follow-up component.
Thanks, Dr. Wu. So, Jigger, I'm excited that you all are kind of listening right now. I think this is one of the areas where it's great to have multiple workflows, but there are some things that really just need one best practice workflow. So look forward to hearing back from Cerner in the coming weeks and months on how you think we could optimize the workflow.
And one other thought real quick, when you were mentioning that there's no default for like follow up with specialist in 2 weeks or 1 week, I think the only thing that I have done to get around that is saving my own little templates for follow up. So I have a little quick pick or save template that says follow up with nursing home provider within 1 week of discharge or something like that, to help with that sort of thing. But it's unfortunately an individual process that can't be done, as far as I know, globally, unless you guys know differently.
No, Grace, I'm curious. The feedback we've gotten from some of the hospitalists with that is they can create their saved templates, but to your point, it's very generic, right? Follow up with your primary care physician. So are you just instructing the HUC or nursing or case management, whomever's scheduling the appointment, that if I order follow up with PCP in 5 to 7 days, that they're just to use the PCP that is listed in the chart? Or that's been our struggle, is they really kind of want validation from the hospitalist of who is the PCP in the order or in the instruction.
Yeah, so our blue banner bar has the PCP, so in it, which is I think we have been working towards better accuracy and completeness of that field. So it's relatively easy, as far as I've been told from our unit secretaries, to be able to readily find who the PCP is. I haven't really heard any complaints from other hospitalists that that they're struggling with knowing who to get the appointment scheduled with.
Okay, thank you so much.
Mm-hmm.
Dr. Halford, anything else on that?
I don't think so. It's, you know, like we've said on other things, I hate that we're all suffering together, but it's also kind of validation to know that others kind of see the same item. So hopefully, you know, we're happy to share as we come back to what our full optimization plan is. And then I'm sure, not to put Jigger on the spot, but I'm sure that Cerner would be happy to share with us if they come up with some recommendations, whether they be for workflow or for development. Thank you, Brian.
No, thank you for bringing that up and showing that to us. According to the agenda, it was really the open discussion in the roundtable, but I see that Dr. Clark joined us here. Thanks for joining. And so when he joined, that kind of reminded me, I did want to bring this up to the group as well, and just get everybody's thoughts on the use of Dragon, and if you're using like Dragon Medical One, and if you're having any performance issues between Dragon and Cerner and how those two are working together. I know some organizations have issues with crashing and performance, and Dragon kind of eating up the memory in your Cerner sessions and causing crashes. But just wanted to get people's thoughts on that, or if you're seeing any of those same type of issues. Dr. Clark, you're much closer to these type of things than I am, but anything you wanted to add?
Well, talking about shared pain, we're just trying to figure out if we're alone or here. We've been working with Nuance and Cerner for now 12 months, trying to get an updated version that doesn't kill our providers, but we're finding our performance issues continue to be one of the major dissatisfiers. It translates to the end user is that, you know, it's a Cerner issue, although I think it's really maybe more on the Nuance side, but be that as it may, it's just causing people to have to log out of sessions. We have to sometimes totally kill this Citrix session or do a Cerner session cleanup just to try to get people back to work. And I'm just wondering if our experience is different than others. And I will say we're using Dragon. We do almost no dictation, transcription at this point. So we're very reliant on it, and we're a dying doc shop.
Hey, this
Paul,
is
do you know what version?
Murray.
Go ahead.
We use Dragon Medical One. When we first converted back at the end of 2018, we did have a lot of issues with crashing and sessions kind of getting hung up. But I think it was fixed because they found that there was a memory leak in Dragon, and once they fixed it, it has been behaving much better. So I haven't heard personally or through our IT department of many complaints of recurrent crashes that we were experiencing almost 2 years ago.
Anybody else have experience with Dragon? Is it working well or not?
I apologize, Dr. Clark, but Covenant Health uses M-Modal. We're not a Dragon customer, so I can't.
Are you having good experience with M-Modal?
Absolutely.
You are. Okay, good.
And I'll also say that our facility uses Dragon pretty heavily, and our physicians are very dependent on it. So my assumption that I haven't heard any complaints about recurrent Dragon crashes these days. I assume that that it means that it's been going much better.
Great. Well, thank you for that. I just wanted to bring that up and get the group's thoughts on if they were having any issues with Dragon. Dr. Halford, from an M-modal perspective, was there, that's fully integrated into Cerner for you, isn't it? There's nothing that sort of sits outside?
Correct. We had to, early on in the discussion, and I don't want to speak for Cerner, but early on, it's kind of like some other third-party vendors, there was a strategic partner. And so at least where we were in our timing, we had to do a lot of calls with Cerner to get that well aligned. I think there was only maybe one other major client ahead of us. We are remote hosted, and we do have connectivity engines on our servers to make that integration work. But yes, I think that's in place for several clients at this point.
Okay, yeah, I know of a couple others that are using M-modal as well, and they've been pretty happy with it. We've got about 10 minutes left. Does anybody have any other general questions or thoughts they wanted to put out to the group? So our next meeting is scheduled for April 7th. That's to be one of our innovation sessions where somebody can talk through something that your organization is doing. We've been through a lot of the organizations so far. I can put this out to the larger group, but I'll ask this group if there's anybody that wants to take the April session and talk about anything that your organization may be doing, either from an application standpoint or a governance structure, if there's anything that somebody wants to talk about. All right, well, I can throw that out to a larger group and see if anybody is interested in doing that. All right. Well, if there's no other questions or comments, I can give everybody back a few minutes to probably prepare for your next meeting. As always, we do put these notes out on our website, so I'll make sure that we send the link with the minutes and everything like that, so you can go and see the reference materials afterwards if you need to. But appreciate everybody for joining here again today, and we will talk again in April. Thank you, everybody. Have a good day.
Thank you, Brian.
Bye, everyone.
Thanks, Brian.
Oh my God, no. That was hilarious.